Welcome back to the Deep Dive. Today we're tackling one of the most high-stakes pharmacological balancing acts in all of medicine, keeping a solid organ transplant alive. This deep dive into pharmacotherapy is critical because we're not just managing disease, we're managing the body's fundamental, rejection of new life.
That's the perfect way to frame it. Organ transplantation is just, well, it's a miracle for patients with end-stage organ failure, but the core challenge we face immediately post-op, and frankly for the life of the patient, is the immune system's ability to tell the difference between self and non-self. That transplanted organ, the allograft, it's foreign, and without lifelong immunosuppression, rejection is pretty much inevitable.
And the numbers really highlight why managing these drugs perfectly is so crucial. Our sources cite over 100,000 patients waiting for a transplant in the U.S. with, well, significantly fewer procedures actually performed. Every single transplanted organ is incredibly precious.
Exactly. It mandates a rigorous, highly specialized approach to pharmacotherapy to ensure long-term patient and allograft survival.
Okay, so our mission today, geared specifically toward you, the advanced learner, is to quickly gain the clinical wisdom needed to move beyond just memorizing lists. We're going to unpack the key drug classes from Chapter 48, connect their mechanisms directly to the T-cell pathway, and, maybe most importantly, explore the critical monitoring points that really define clinical decision-making. Okay, let's unpack this. Before the drugs, we really have to understand the core target, T-cell activation.
Right. T-cell recognition of that foreign tissue is basically the starting pistol for rejection. We're talking about the high traffic area of T-cell activation, which relies on three distinct signals to launch its attack. If we block any one of these, we stop the cascade.
So let's jump right into that cascade, the three signals that define our drug targets. What's signal one?
Okay, signal one is recognition. You have an antigen-presenting cell, an APC, presenting the donor antigen via MHC to the T-cell receptor, the TCR. This immediate recognition causes a massive influx of calcium into the cell, which then activates an enzyme called calcineurin.
Ugh, calcineurin. I think I know where this is going. That's a big drug target, isn't it?
The huge one. So calcineurin then goes to work. It dephosphorylates NFAT, that's nuclear factor of activated T cells. NFA then zooms off to the nucleus and starts producing the key chemical messenger, interleukin-2, or IL-2.
Wait, so calcineurin is essentially the absolute master switch for this entire cascade kicking off.
It is the crucial enzymatic trigger, absolutely. If you stop calcineurin, you stop the T cell from making the essential tools it needs to, well, start the fight.
Got it. So signal one is the initial spark in making the messenger IL-2. What does signal two, costimulation, add to the mix?
Signal 2 is really the amplifier. You get the CD8DO86 receptor on the presenting cell binding to the CD28 receptor on the T cell. This binding significantly enhances signal 1, promoting a much more IL-2 formation. It's kind of like the go faster button.
Okay, amplification. And signal 3 must be the result, the actual T cell war party starting.
Precisely. The newly made IL-2 acts on its own receptor, which is CD25, and this activates the mTOR pathway. This is the stage of massive T-cell proliferation and progression through the cell cycle. So you've got recognition, signal 1, amplification, signal 2, and mass production, signal 3. Nearly every single drug we're going to talk about targets one of those 3 points.
That gives us a really clear framework.
Yeah.
Okay, now let's divide the therapeutic approach, the short game and the long game. Induction therapy, that potent perioperative suppression and maintenance therapy, the lifelong regimen.
Yeah, induction is kind of the shock and awe strategy, right? To prevent early acute T-cell rejection, which can happen fast. The most potent agents are the lymphocyte-depleting agents, and rabid anti-thymocyte globulin, or rATG, is definitely the preferred standard now. Clinical data clearly showed the rabbit-derived stuff had superior outcomes compared to the older horse-derived product.
Superior how?
Better allograft survival and less rejection, plus a lower risk of allergic reactions, which was a bigger issue with the horse product.
Okay, so rATG essentially just wipes out the peripheral blood lymphocytes. Given that intensity, what are the absolute non-negotiable safety checks for giving rATG?
Right, well, first, pre-medication is mandatory. About 30 minutes before the infusion. Acetaminophen, diphenhydramine, and methylprednisolone. That's to manage those common infusion reactions like fever and chills. But the one thing you absolutely must remember is monitoring for cytopenias. bone marrow suppression.
Why are those specific cytopenia numbers so critical? Why the exact cutoffs?
Because if the patient's immune system gets too suppressed, the risk of really life-threatening infection just skyrockets. It's a fine line. The dose must be decreased by 50% if platelets fall into that 50,000, 100,000 cells ml range, or if the white blood cell count drops to 2,000, 3,000 cells ml. And if they drop below those thresholds, you have to stop the drug immediately, full stop.
Very clear boundaries for safety. Okay, now, for the non-depleting induction choice, Basiliximab, how does that differ?
Basiliximab is, well, it's a much simpler mechanism. It's a monoclonal antibody that specifically targets the IL-2 receptor, CD25, so it blocks signal 3. It prevents the T cells from proliferating, but doesn't cause that immediate cell lysis, that killing off of cells like rATG does. Generally less immunosuppressive overall.
And dosing.
Easier. Much simpler. It's just 20 milligrams on post-op, day 0, and then again on day 4. That's it. The effect lasts about 3 to 4 weeks. And interestingly, randomized trials showed it had no more side effects than placebo. Pretty well tolerated.
Okay, great. So we made it past the initial acute phase, the induction. Now for the long game, maintenance therapy. And here's where it gets really interesting, I think, because the calcineurin inhibitors, the CNIs, Tacrolimus, Cyclosporine, they form this like toxic but absolutely necessary backbone.
That's exactly right. The CNIs are essential because they block signal 1, remember, by inhibiting calcineurin. Tacrolimus is a macrolide that binds to something called FK506 binding protein, FKBP. Cyclosporine is a polypeptide that binds to cyclophilin. Different binding partners, but same end result, inhibiting calcineurin. What's really fascinating here is the sheer potency difference. Tacrolimus is something like 40 to 50 times more potent than cyclosporine.
Wow. So if both cause the dreaded nephrotoxicity and neurotoxicity, how do we even choose between them? Is it basically trading like nerve issues and diabetes for gum issues and extra hair?
That's often the clinical reality, yeah. And table 48.1 in the chapter really helps visualize that comparison. Both cause significant kidney damage acute, which is often reversible vasoconstriction, and chronic, which is scarring interstitial fibrosis. Both cause neurotoxicity too, like tremors. But yes, we often differentiate based on those secondary, sometimes nuisance factors. Tacrolimus is more associated with neurotoxicity, tremors, sometimes even seizures, and definitely a higher risk of new-onset diabetes after transplant. That's a big one. Cyclosporine, meanwhile, hits the aesthetic side maybe a bit harder. Gingival hyperplasia, that gum swelling, and hirsutism, the unwanted hair growth.
Okay, got to warn patients about those specifically. Now, the interaction headache. If these drugs are the backbone, we absolutely have to know their complex metabolism. What kinds of co-medications or even foods pose the biggest threat?
Oh, it's huge. We must remember they are major substrates for both cytochrome P450-3A4, CYP3A4, and P-glycoprotein. This makes them absolute interaction sponges. So you need to counsel patients constantly about 2 major categories of risk. First, CYP3A4 inhibitors. Think azole antifungals like fluconazole, macrolide antibiotics like erythromycin, certain calcium channel blockers, diltiazem, verapamil. These will rapidly increase CNI levels, potentially leading to catastrophic toxicity. Very dangerous.
And the food interactions, you can't forget the famous fruit warning, right?
Never forget the fruit warning. Grapefruit, pomegranate, and starfruit are significant CYP3A4 inhibitors and absolutely must be avoided, period. Conversely, you have the CYP3A4 inducers, things like rifampin, phenobarbital, phenytoin, St. John's wort even. These will decrease CNI levels, putting the patient at immediate risk for organ rejection. Patients absolutely must call their transplant team before starting any new medication, prescription, or over-the-counter.
That's a critical counseling point. And a quick check on pharmacodynamics, the other drugs that can hurt the kidneys alongside CNIs.
Right. Definitely avoid NSAIDs if possible. That's a cumulative nephrotoxicity risk, a double whammy. And be extremely cautious with ACE inhibitors, ARBs, and potassium-sparing diuretics like spironolactone. They raise the risk of hyperkalemia, high potassium, and acute kidney injury when combined with CNIs.
Okay, moving on from the backbone CNIs to the standard adjuncts. Antimetabolites. Mycophenolic acid derivatives, MMF, which is Celsepti, and Myfortix, seem to be the typical choice now.
Yeah, MMF's elegance really lies in its specificity. It blocks de novo purine synthesis by inhibiting an enzyme called IMPDH. Because B and T lymphocytes really rely heavily on this pathway to proliferate, it halts their progression without significantly affecting the salvage pathways used by most other cells in the body.
Okay, targeted action. What are the common issues?
The most common problems are dose-related GI side effects, nausea, diarrhea. These often get better with a dose reduction or sometimes switching between the formulations, like from MMF to Myfortic, which is enteric-coated. It can also cause neutropenia, low white blood cells.
This drug, however, carries a huge, non-negotiable safety conversation. especially with women of childbearing potential.
It absolutely does. MPA is subject to a strict FDA REMIS program, risk evaluation and mitigation strategy. It is absolutely contraindicated in pregnancy. There's a high risk of first trimester pregnancy loss and severe congenital mammophy malformations. Any woman who could become pregnant must use highly effective contraception during therapy. And if pregnancy is planned, they must be switched off of MMF at least 6 weeks before attempting conception. That's critical.
Super important take-home message there. Any key interactions for MMF?
Yeah, a couple of big ones. Cyclosporine actually inhibits MPA's enterohepatic recirculation, which reduces the overall MPA exposure, so doses might need adjustment if used together. And MPA should not be given with antacids or iron supplements, as they chelate it and significantly reduce absorption, separate the timing.
Okay, and briefly, the second-line antimetabolite, azathioprine. What's the major drug interaction we need to have on our radar?
The major interaction pearl for azathioprine is allopurinol, the gout medication. Allopurinol inhibits xanthine oxidase, which is the enzyme needed to metabolize azathioprine. If you give them together without adjusting, you get massive toxicity risk. You must reduce the azathioprine dose by about 75% if a patient is also on allopurinol.
75% reduction. Wow. Okay, finally, let's touch on the mTOR inhibitors, sirolimus and everolimus. These are also signal 3 inhibitors, right? But they work differently.
That's right. They also block signal 3, T-cell proliferation, but they work downstream of the IL-2 binding to its receptor, inside the cell signaling pathway. They are generally considered less immunosuppressive overall than the CNIs, and often reserved for situations where CNI toxicity is the limiting factor.
So used when Tacro or Cyclo are causing too many problems.
Exactly. Or sometimes they're chosen for their potential anti-tumor properties, which is an area of ongoing research. However, they carry their own unique set of risks. Box 48.2 in the chapter emphasizes significant hyperlipidemia and especially hypertriglyceridemia. You must screen baseline lipids. In fact, triglycerides greater than 350 mg/dL is considered a contraindication. They also classically impair wound healing, which is why loading doses are generally avoided and they aren't typically started immediately post-op. And other potential issues include pneumonitis, lung inflammation, and proteinuria, protein spilling into the urine.
Got it. And we can't possibly forget the broad-spectrum players, corticosteroids, like prednisone or methylprednisolone. They seem to be used everywhere. Induction, maintenance, even treating acute rejection episodes.
Yeah, they're the old reliable, in a way. Their mechanism is broad, they inhibit cytokine production, decrease lymphocyte output, lots of anti-inflammatory effects. But this broad effect, of course, means broad side effects. We're always monitoring for acute issues like high blood pressure, blood glucose swings, sometimes even confusion or mood changes, and then the well-known chronic issues. Osteoporosis, cataracts, weight gain, central obesity, that classic moon face. Long-term use requires careful management.
Okay, let's look at the newest frontier for maintenance therapy, specifically tackling signal 2, belatacept. This is Costimulation Blockade.
Belatacept is, it's quite clever pharmacologically. It's a fusion protein designed to bind to CD80 and CD86 on the antigen-presenting cell. By doing that, it physically blocks the critical CD28 interaction with the T-cell, effectively preventing signal 2, that amplification step.
Sounds like a great targeted approach, but I sense there's a catch. A significant safety concern.
There is a big one. It's associated with a higher risk of post-transplant lymphoproliferative disorder, or PTLD, which is a type of lymphoma, particularly in a specific subset of patients.
Okay, what is the non-negotiable contraindication for belatacept based on this risk?
It absolutely must not be used in transplant recipients who are Epstein-Barr virus, or EBV, seronegative meaning they've never been exposed to EBV, or if their EBV status is unknown. You must know the patient's prior EBV exposure status before even considering prescribing this drug. Using it in an EBV-negative patient puts them at a significantly higher risk for developing PTLD. Mandatory screening.
Wow, okay, crucial safety check there. So bringing it all together now, for you, the learner listening, what's the core decision algorithm look like? What is the standard regimen and what factors push us to switch agents around?
Well, the classic, most common maintenance regimen is still triple therapy: Tacrolimus, MMF, and prednisone. Though, as I mentioned, steroid-sparing protocols are becoming increasingly common, trying to minimize long-term steroid toxicity. The initial choice depends fundamentally on the immunogenicity of the organ being transplanted, for instance. Pancreas transplants are considered high immunological risk, liver is generally lowest risk, and patient factors matter hugely too, like the number of HLA mismatches between donor and recipient, the patient's overall immune status, and their individual risk factors for specific drug toxicities.
And when do we typically switch things up?
Oh, switching is very common, primarily because toxicity is almost universal with these drugs long term. Like we discussed, if a patient develops debilitating neurotoxicity on tacrolimus, we often switch them to cyclosporine. If severe GI intolerance happens with MMF, we might swap it out for azathioprine. The mTOR inhibitors, sirolimus or everolimus, are usually considered third-line agents, typically reserved for when CNI toxicity, especially kidney damage, becomes dose-limiting. We also tailor therapy based on populations. For instance, older patients generally have a lower inherent rejection risk, so providers might aim for slightly lower overall immunosuppression levels to mitigate infection risk, which can be higher in the elderly. And there are some considerations around ethnicity. African American patients often have a higher risk of acute rejection, sometimes warranting higher MMF doses, while some data suggests Asian patients might be at higher risk for infections at standard doses, sometimes warranting lower initial MMF doses, but these are generalizations, of course.
It sounds incredibly individualized. And the final overarching message here has to be about adherence and safety, right? The complexity of this regimen means the patient themselves plays perhaps the largest role in long-term survival.
Absolutely. Lifelong medication adherence is probably the single largest predictor of long-term allograft survival. Missing doses is incredibly risky, and as clinicians, we must constantly monitor for the three big threats: rejection, infection, and drug toxicity. It's a continuous balancing act. And given that drug interaction trap we talked about, the explicit counseling to avoid certain foods like grapefruit, and crucially to contact the transplant team before starting any new prescription, OTC drug, or even herbal supplement, that might be the most important clinical conversation you will have repeatedly with these patients.
Wow, okay, that was a dense but really fascinating dive into this intricate pharmacological balancing act. We covered the three signals: recognition, amplification, and proliferation, and how basically every major drug targets that cascade somewhere. From the initial shock and awe of rATG induction to the lifelong challenges and dilemmas of managing the CNIs like tacrolimus and cyclosporine.
Right, and the key takeaway for you, the learner, is really that constant clinical tension. You're always trying to find the sweet spot, enough immunosuppression to prevent rejection, but mitigating the very real risks of infection and long-term drug toxicity. And it's worth remembering what the sources note: cardiovascular mortality remains the leading cause of death for long-term kidney transplant recipients. That's often linked to the side effects of these drugs.
That chilling fact gives us our final provocative thought for you to explore. Knowing that cardiovascular mortality, often driven by issues like hypertension, dyslipidemia, and diabetes that can be exacerbated by CNIs, is the leading long-term complication after transplant. How might the accelerating trend towards CNI-sparing regimens, perhaps incorporating agents like belatacept more frequently, fundamentally redefine the long-term management goals and maybe even outcomes for transplant recipients over the next decade? Something to chew on. Thank you for joining us for this deep dive into organ transplant pharmacotherapeutics.